Hi, I'm Joel Bloom, president of New Jersey Institute of Technology. At NJIT, we believe that not only our students, but all citizens need to be informed about the issues facing higher education. As New Jersey's Science and Technology University, NJIT is proud to support the important programming produced by the Caucus Educational Corporation and their partners in public television.
The state of healthcare, next on Caucus New Jersey.
Funding for this edition of Caucus New Jersey has been provided by Wells Fargo, the New Jersey Education Association, NJIT, New Jersey Institute of Technology, United Water, making the planet sustainable is the best job on earth, New Jersey Sharing Network, dedicated to saving lives through organ and tissue donation, Kessler Foundation, changing the lives of people with disabilities, and by Choose New Jersey. Our mission is attracting companies to the Garden State.
Hi, welcome to Caucus New Jersey. I'm Steve Adubato. So what exactly is the state of healthcare in New Jersey and in the United States of America? Here to discuss that very important question. We have four experts on the subject. First, Joe Berardo, Chief Executive Officer, MagnaCare. Robert Garrett, President and CEO, Hackensack University Health Network. Annette Catino, President and CEO, QualCare Alliance Networks. And finally, Dr. Jeffrey LeBenger, Chairman and CEO, Summit Medical Group. I want to thank all of you for joining us and dealing with this not very complicated subject. Bob Garrett, what exactly is, seriously, the state of healthcare in New Jersey and the nation? By the way, are they a different question? Is that a different question?
You know, I think it is a different question, but in some ways, New Jersey is a microcosm of what's going on in the nation. You know, I think certainly there's been some progress under the Affordable Care Act, Steve, but there are still some challenges. There's still challenges in terms of access to health care. As an example, in New Jersey, as Medicaid has expanded, some of the people who are newly insured by Medicaid can't find primary care doctors, as an example, because there are a lot of doctors that are not accepting Medicaid because the rates are so low in New Jersey. Actually, I think it's the second lowest in the nation as far as Medicaid reimbursement. Access to health insurance continues to be a challenge. Certainly, more people are insured in general in New Jersey and in the U.S., but there still continues to be issues. There was just an article I read in the Wall Street Journal this weekend, and it talked about the fact that premiums have gone up significantly even under the Affordable Care Act. So it's still a challenge for people to be able to afford health care. And then the third piece, which I think is very true both in New Jersey and in the nation, is there's still a significant shortage of physicians in general, specifically primary care physicians. I think the number in New Jersey is 3,000, nationally 90,000 by the year 2020. So that continues to be a challenge.
Don't have enough.
We don't have enough. As more people are insured, there's not enough doctors.
Jump in, Annette. State of health care. By the way, I'm not going to say good or bad because it's much more complicated than that. We've been talking about this for a few years together, right?
Yes, we have.
How would you describe it?
Changing every day. Consolidation happening at the national level, consolidation happening at the local level, hospitals and doctors getting together, hospitals and payers getting together, doctors and payers getting together.
Out of necessity?
I think out of a belief that to deal with the changes, you need to be larger, you need to have some scale, you need to cover a larger geographic area to take care of people better, and you need infrastructure to support that, and that all costs a lot of money. So, you need to share those resources across larger health systems.
And by a couple of things, Annette is actually a board member of the Caucus Educational Corporation, and recently, a few months ago, let's make it clear, your organization became bigger?
Yes, we did. We are part of the payer consolidation that's going on across the country, and my company was acquired by Cigna, Health and Life Insurance
Mr. Garrett, you guys have a bit of a...
We have a merger planned with Meridian, so we'll be an 11-hospital system, about a $4 billion healthcare organization.
So things are changing everywhere. Jump in, Joe and Jeff, talk about this. Because as Annette and Bob talk about a lot that's changing on that side, talk about what you think it means to patients, consumers.
Well, I think just to build on what they said, what's occurring is we're building systems of care, right? And Jeff can certainly comment on this, so can Bob. But in order to move towards a reimbursement methodology that's going to be different than what we're doing today, in order to have the population be taken care of appropriately at the appropriate price, organizations in the provider community really have to be prepared to have all types of service, from inpatient to all of the things in the community that are necessary to deliver care to patients. So I think what's going on is a transition of really where the premium dollar goes. Like, all of this has always got to do with money and financing and rates. But
does it?
Yeah, of course it does. So I think it's a function of the providers have to get more control of the dollar. What Annette and I do for a living, and really we've both been doing the same thing for a while, is we administer health plans. We actually are the distributors of the product, which are these organizations. So, I think what you're seeing is a coming together, which is probably going to increase costs for a period of time because it's expensive.
Why? Hold on, wait a minute, back up. Why would it increase cost, in your opinion, if in fact it's designed, Joe, to decrease cost?
Because I believe, as Annette said, to invest in the technology. When Bob's organization buys physicians, they become part of a bigger system. There's more negotiating power. Jeff's got a very sizable organization here in the state. In the current fee-for-service environment, that commands a bigger price. So what's going to happen, though, over time, and I think everybody's gearing up for it, it's going to be more of, you sell a premium, you might turn around and say, listen, here's 92 cents or here's 93 cents for each dollar. You go manage the patient. We'll take care of administrating the claim and doing the sales and organizing the ID cards, all the administrative stuff around the plan. But really, these guys will become the center of the product, not the insurance companies.
Jump in here, Jeff. And by the way, make it clear what Summit is.
Summit Medical Group is a large multi-specialty group in the state of New Jersey, north central New Jersey. We have approximately 600 providers within the group. We look at the patient. We always look at the patient, and we try to give a quality product at a lower cost point. And what we've seen is we try to drive the care of a patient to a lower cost point. We all know that when you're in a hospital, it's a very high cost point. A lot of care that is provided in the hospital can be done on the ambulatory side at a lower cost. We try to look at the quality metrics within that to be able to provide the patient with a quality product in it. But what we have seen in the state also is that everything is moving, and Joe and Annette could tell you this, to a high deductible premium.
High deductible. Break this sort of this down, because a lot of this is hard for people to follow. A high deductible premium.
Right, so they could probably explain it better, but there's a co-share now in the payments that the patient has to pay some of their premium dollar.
Go ahead.
So a lot of plans have a $2,500 deductible, $5,000 deductible. So now people are looking in the state where they could have their health care at a lower cost point with high quality metrics.
Bob, is this doable? And by the way, does this have to happen, that we as consumers have to do this? I'll get you right back in on that.
Yeah, I think it does. And, I want to pick up on what Jeff said. The world is changing. I mean, when I grew up in the healthcare world, the center of the healthcare universe was the hospital. But
the hospital?
Was the hospital, but more and more care is being delivered outside the hospital for the reasons that Jeff pointed out. If you're going to an emergency room for something very, very minor, that's not the most efficient place to be treated. You might be better off being treated in an urgent care center. If you're seeking some basic primary care, you might seek that in a retail healthcare setting as opposed to a hospital. So hospitals and health systems are changing their business model to really diversify as well, to really reflect these changes, but more and more care is being delivered outside the four walls of the hospital.
And just to pick up on something that Jeff said, because I think it's very important that the audience understands it. The reason why high deductible plans are really coming into vogue in higher numbers today is really a direct result of the Affordable Care Act. The Affordable Care Act put in place a premium tax called the Cadillac tax.
The Cadillac tax.
The Cadillac tax, like the Cadillac that our fathers drove.
Right.
That said, an employer who paid more than, on average, $18,500 for the cost of health care coverage for an employee's family would be subject to a tax. Because remember, most people in America get their health insurance through their employer still, and it's not taxable. So this was trying to get at the tax base of health insurance premiums. So the government put in place this Cadillac tax that said by 2018, if your plan costs more than $18,500 that your employer's paying for it, that's going to be taxable as income.
And then the individual is going to have to pick up.
That's correct. So what employers have done is they've sat down, they've analyzed the cost of their plans, and they said, if I escalate my plan over the next 5 years and my plan's going to exceed that number, I need to do something now about it because my employees don't want to pay tax on that plan.
That's right.
So they're moving to these high deductible plans that have a $5,000 or a $2,500 deductible associated with it that brought the cost of the plan down so that they didn't have to worry about that Cadillac tax.
Okay, as you're talking about this, I'm realizing that all four of you healthcare experts have been living it, working in it for many, many years. Can you understand why the average person is sitting there saying, how the heck are you supposed to, how am I supposed to keep track of this? I have a job, I've got a family, I hopefully have a job, and if you don't, we hope you get one soon. How am I supposed to keep up with this, Joe?
No, it's when we were gathering earlier, I was at the doctor's office on Monday, and I sat in the waiting room watching people at the window just have trouble understanding how they were covered, what they had to pay.
And that's not even this policy conversation.
No.
Go ahead.
And to add to the complexity that Annette said, there's also a minimum value. So
are you going to complicate it, Joe?
Yeah,
Thanks.
we have a Cadillac tax. We also have minimum value. And there's an element of affordability that has to be plugged in, meaning an employee can't be paying more than 9.5% of their gross income towards their health plan. So there's a bunch of parameters that employers, employers coming into next year have a lot of work to do on compliance.
Hold on, back up. Employers have a lot of work to do with compliance, but here's the thing. The issue of transparency is continually talked about. You have to be more transparent. But here's my dilemma. If you are being transparent and communicating information that the average consumer is sitting there saying, I have no idea what you're talking about, how valuable is that transparency, Bob and then Jeff?
That's the point I was going to pick up on what Joe said is I think we have a responsibility to not just be transparent, but to also educate the public on what this all means. So, it's great to post your prices, but then they have to understand what that means and what they can expect. So we actually have educators now that are helping people understand some of these changes that are going on in healthcare, changes to their insurance plan the best we can, or if we can't answer the question, we direct them to others. But we actually have a team that is involved in education.
Right, but in terms
How do you deal with that?
But in terms of pricing, all providers have a charge master. But
A charge master,
what you charge the patient. So it is a retail price of charging. But there is contractual write-offs when you have insurance that you don't get that dollar. So routinely, patients see bills of maybe $30,000 for a procedure or being seen, but it's not true. The contractual write-off is there for the insurer, and the physician is only getting, or the facility is only getting, maybe $2,000 or whatever.
Well, then why does the bill say 30 grand?
Because it's just how the billing process is pushed through.
But Jeff,
it's contractual that they really need to see, and the transparency really needs to be on the contractual obligation that patient needs to pay to be seen and what that provider is receiving. So it's very different.
It sounds like what you just, my interpretation is, listen, what we need to be transparent about is what we're going to tell you isn't really accurate, but we need to tell you it's not accurate.
No.
Okay, what?
So the technology, what's interesting about all this now is the technology's there to allow it. So there's companies there's Castlight, there's Healthcare Blue Book, there's Vitals. So what you're seeing, and we're actually launching something here at the end of the year based on about 3 years of our historical data. Members will be able to go on to a very user-friendly website and look at whether it makes sense to get an MRI in their zip code area, at a freestanding facility or at a hospital, and there's about 200 different procedures, right down to things that can be packaged into a bundle at a surgery center.
They could find that through.
But what's interesting, I think what's going to change here is the tools that are now being introduced are going to incent the members to make decisions that might be more cost-effective to their plan.
Don't they have to do that in consultation with their physician, though?
They do, but the biggest challenge we have in healthcare is that the consumer does not understand the product they are buying. That's our biggest challenge. We can sit here and say, well, you can go price an MRI. if you talk to the average consumer, they don't know what they need an MRI for. They just maybe heard their friend hurt their knee and they got an MRI, but they don't understand what they need it for. Our challenge in healthcare is that the consumer, this is the only industry where the consumer doesn't know what to buy.
You go,
And
you're
they
buying a car. Go
rely-
back to okay.
They
You want
rely
to go buy
on
a
their
car?
physician. Yeah, exactly. If I want to buy a car, I can go to websites. I can look at the engine size. I can look at the tire size. I can look at how efficient it is from a gas mileage. When I get sick and I'm not feeling well, I rely on my physician to tell me what I need. That's the relationship that needs to be transparent, and the physician needs to know some of the cost information.
Having said that, and I agree with what Annette said, having said that, I think consumers in general are getting more involved in their healthcare. They are being
saying
more
that, Bob?
educated. Yes, and through technology, you know, their mobile apps, you know, are giving them more information. They're tracking their symptoms. They are checking emergency department wait times. They're getting more engaged. It's true. They're still very reliant on their physicians, but hopefully over time, when technology allows, they will get more and more involved, because I think that's best for them. It's best for their health care. It's also best for the healthcare system, because then they'll be educated to make the right choices to get the best quality health care at the lowest cost.
They're becoming more involved in their own health care, in their own health care
Give us an
decisions.
example of that, Tim. Of really being involved. And by the way, not that it excludes the physician, but Annette is saying, and I believe a lot of people are appreciating what she's saying about, I'm confused, but I also appreciate the fact that there are some people saying, I'm on the internet more, I'm using technology. There are a range of people out there.
Absolutely.
But give us an example of what you're saying about patients being more engaged in their own health care.
Well, take it down to a simple level of
Yeah,
a
very
patient coming
simple.
in just to see. I still am a practicing physician, but they come in and they ask me about care. Let's say I have to do a tonsillectomy on a child. They'll come in, they'll speak to me about a tonsillectomy on a child, and they might go for a second opinion, they might not. In the years past, nobody asked me, where are you doing the surgery? What are the costs involved with the surgery? Is the surgical center in network, not in network?
They're asking now.
They're asking now, absolutely asking now, because they now have a deductible that they have to satisfy for it. And they're getting more involved in asking the questions. And they even ask questions, is it necessary for my child to have that procedure or for me to have that procedure? For instance, orthopedics. You have a bad knee. It's almost invariable. You go to an orthopod, he's getting an MRI on that knee. You don't need to do an MRI on every knee. Or you have a headache. People come in with a headache, and the biggest costs are MRIs.
Believe me, I've been there.
Right,
CAT
and
scan, MRI.
Right, and everybody wants an MRI if they have a headache. You don't need to have an MRI for every headache. There are evidence-based medicine algorithms that tell you when to have them, when not to have them,
And sorry for
and go
interrupting,
to
and the
correct
patient should be
doctor.
doing what in that? Along those lines, the patient, because Annette's saying the patient's depending upon the doctor. You say.
But I think the patient also has to be part of it. The patient has to be educated. My daughter, who's 24 now, she Google searches every illness, everything, and she tells
Good
me,
point.
boy,
I think
should
it
I
is
do this, should I do
generational.
that, whatever.
There's no
It's
question.
generational.
It's
It's
absolutely generational.
Talk about that.
Generational in that, you know, clearly the seniors who have a lot of time do a lot of research on the internet, and they come to their doctors with advertisements and with pieces of paper that they found that this would be helpful to them. The younger generation Googles everything. They Google everything. They check their friend's Facebook page to see who went for what and where they went and what kind of an outcome they had. The middle-agers, the people in the middle, are still trying to use technology to help them. So I do think when this younger generation is in our age category, you're going to see more of that technology being applied to healthcare.
And just picking up on that a little bit, the younger folks, I think, want instant service.
Absolutely.
They want physician appointments the same day. They want results the same day.
Is that,
You can see it.
interrupted, Bob, is that why the mobile app that you talked about?
Mobile app's very important.
Telemedicine.
Our telemedicine is very important. Medical groups allowing for same-day appointments, very, very important, because as you know, as more of our population is more technologically savvy, that's what their expectations are.
Let me ask you this, Joe, from your perspective, how much does all this change? I'm fascinated by this, the potential relationship between a patient and his or her physician. Because a lot of what's being said here is the conversation between patients and their physician, potentially the dynamics, the whole thing is different.
I think Bob hit something earlier, is the primary care physician. You know, I started in the business 26 years ago in an HMO where you were required to pick a primary care physician when you joined the plan. And the thought process back then is the primary care physician was going to be your quarterback.
Right.
Not as much technology.
Who's the quarterback now?
You know, the internet. So you know, it's a shame though, but I think the provider relationship is really core, because we as health plans, we can send text messages, we can send reminders, go get a mammography, go do this, go do that, because we have all the data, we can see everything. If he calls, they're coming into the office.
Right.
If I send them a postcard, it becomes a coaster.
Right.
You know, it's
But
not.
the doctor still is the most important voice, correct, Joe?
The physician-patient relationship is absolutely changing in the new age of technology with the electronic medical record. Years ago, when the electronic medical record...
Describe that for people who don't know what that
so
means.
electronic medical record is that all your data, all your sourcing of that patient information is now on a unified chart within the computer. In the years past, you used to see a patient and used to be able to spend time and get to know the patient and ask the patient questions, really know their family, what's going on with them. And it was really a lovely way to handle a patient in the past.
Today?
Now it's impersonal. Now
Wow.
you see a physician, he's usually looking at the computer, trying to enter data while talking to the patient and examine the patient. Because how medicine is moving to the so-called population health metrics, you have to add all these metrics and know when to get the colonoscopy, when to get the mammography, when to do your lipids, when to do this, when to do that, and you have to add it into the chart. So it's becoming a little impersonal.
Jeff, respectfully, and Bob and everyone else here, isn't this population health approach supposed to produce better outcomes? And I don't want to simplify things, but
in the
Jeff
population as a whole.
Exactly.
Individually,
Go ahead.
it's an issue.
But getting back to
Great.
what Jeff is saying, though, so beyond even physicians, other practitioners too, even in the hospital setting. So nurses who are interacting with patients are entering data into the computer as they're speaking to patients, because it's just a different way of assessing information.
Yes.
So it is a little bit more impersonal. And when we went live with our electronic health record, we had to train nurses to and physicians for that matter to still, you know, adapt the personal touch.
And two things happen.
Real quick, go
Costs
ahead.
go up and productivity goes down.
Ouch.
Yes.
Let me try this. We've talked about leadership in so many different programs we've done here, and I'm fascinated by the subject, but I'm also fascinated by the subject of leading change. You've talked about a significant merger, your organization, big change. I've done leadership development at your organization and yours as well. And so here's what I'm fascinated by, this question. I usually ask, what's the biggest leadership lesson you've learned? I'm going to ask a slightly different question here. What's the biggest lesson you learned about leading change? Leading change in this incredibly unpredictable healthcare environment. Number one lesson you learned about leading change, Bob Garrett.
You know, I think the old norms don't work. I mentioned at the very beginning of our conversation that the business model is diversifying, the business model is changing. So I think the biggest lesson I learned is that the old skill sets are not necessarily applicable. You need to have new skill sets. You need to be able to adapt to change very rapidly.
Biggest lesson about leading change, Joe?
You know what? I think it's looking for the opportunity in the change. You know, so for our organization,
People are afraid. What do you mean the opportunity?
Well, you know, I was afraid, right? When the law was passed, I'm like, should I be in the
Affordable Care Act.
Should I be, you know, own an ice cream store, or should I stay in healthcare? But I think what we did as a team is we sat back and said, what's the opportunity? And quite frankly, we view the opportunity is getting together with the provider side of the community and figuring out how do you deliver programs and leverage the technology that we've already built and invested in, and have these guys leverage it over time. And I think that's why, you know, we spend time together outside of this studio talking about what's going on in the state and how we can all work together. So I see the opportunity and the change.
And now you've seen a little bit of change in your career?
Yeah, I
Number one
think
lesson?
it's about communicating. You know, you can't take everybody along with you. It just doesn't happen. But you can keep people informed as you move along the curve. And the people that embrace it will come forward with you and really rise to the occasion. And others will be left behind or leave. And you have to accept that, because it's part of growing up. I mean, it just is.
Tough stuff. Jeff, final one.
Agreed. You have to embrace it. It's coming. It's not changing. And I think the biggest thing is you have to make a decision. Right or wrong, you make a decision on the change. And you have to live with that decision and move it. And then you have to be nimble enough if there's a nuance that comes on to shift.
It's powerful stuff. One thing I've learned about leading change is it's coming whether you like it or not, and the only constant is, in fact, change. I want to thank all of you for talking to us about the healthcare changes every day. Thank you so much.
The preceding program has been a production of the Caucus Educational Corporation, celebrating over 25 years of broadcast excellence, and 13 for WNET, NJTV, and WHYY. Funding for this edition of Caucus New Jersey has been provided by Wells Fargo, the New Jersey Education Association, NJIT, United Water, New Jersey Sharing Network, Kessler Foundation, and by Choose New Jersey. Promotional support provided by The Record, North Jersey's trusted source, and NorthJersey.com, and by Commerce Magazine. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. Caucus New Jersey has been produced in partnership with TriStar Studios.
Each year, Americans fill 4 billion prescriptions, but as much as 1/3 of that medication will never be used. Some of this waste ends up in the rivers, lakes, and streams that make up our drinking water supply. The United Water Foundation and the National Community Pharmacists Association have partnered to bring you a simple solution. Dispose your meds responsibly. Go to disposemymeds.org to find a participating pharmacy and to learn more. A public service message from the United Water Foundation and NCPA.